And so what happened was I started like every other lecture, I taught Robbins. And I promise you, after one semester, I went, that's the stupidest thing I've ever seen in my life. Robbins pathology should be banned from medical schools. Not just, it's not a resource. Ban it. It harms medical students.
Okay, Dr. Tisdall, you have decades of clinical experience and you've been teaching for the last 10 years. Talk to me about your experience when you first started teaching.
So I came out of decades of practice, and what you have to understand is when someone says they have clinical exposure, you've actually got to ask what that was. Because if you're coming out of family practice, that's very heavy psychosocial cultural. If you're coming out of internal medicine, well, that's not peds, is it? It's not psych. It's very much adult and very much non-mechanical. But if you're coming out of surgery, everything's kind of mechanical, isn't it? That's what surgery is. So that narrows your scope of what your experience allows you to have judgment on. So when you say, well, what was my clinical experience? I came out of general pathology in small hospitals. And that matters because it meant that I had to work in hospitals with medical staffs of 100 or 200, meaning I had to meet everyone and talk to everyone. So on any given day, I might be working on blood transfusion for our level 2 emergency trauma, to doing a frozen section in the OR, to talking to an internist for a new test they want, and then talking to an obstetrician about why it's so slow for our send out on amniotic fluid for lung maturity. So I really became a jack of all trades and master of none. But actually, that's a very good thing coming into medical education of medical students because they don't really want subject expertise. So I came out of a really good background. And there's two backgrounds that give you a massive advantage when you come to teach medical students. The first is, do you prescribe a lot of drugs? Man, if you've got pharmacology in your belt, that's just the best ever. That's what I always struggle with doing drugs because I was on the diagnostic side of medicine, not the therapeutic side. You know, if you come out of surgery, your anatomy is going to be great. The other thing, though, that pathology uniquely gives you ability in is surgical pathology gives you a strong sense of cells and tissue architecture. And so when I say to you, what is the biggest gap in medical education? There are two things that are very difficult coming out of practice. The first is, can you make the link between the molecular and the patient organ? Always and ever, that's the biggest gap. That, without a doubt, that's the biggest gap in medical education. All your practicing physicians are totally great starting with the patient and getting to the organ. They're all really good at that. And your PhDs are all really good at the proteins and the molecular pathways they're in. But no one can connect them. So start with your shortness of breath and walk me all the way through to dystrophin. No gaps. Yeah, well, everyone's got this giant gap between tissue architecture and cells getting to the proteins. Well, how do you talk about medicine without talking about cells? Well, anything you don't have a mental picture of, you memorize a word, which is not understanding. The biggest problem for me, because I had that big hole plugged coming out of pathology, the biggest problem for me was, what is the right level by which you can talk to a first or second year medical student and they understand? And 12 years later, I still haven't found bottom. I'm still looking for, have I set it at a level that a student will internalize the conversation and not memorize the word saying, is this going to be on the exam? This is a sense of the problem that you face for a medical student. You have to build understanding. A medical student is built, not just have a whole bunch of facts dumped in, stir it up in your mixer, and voila, clinical experience. It just doesn't work like that. So for example, I'm at this new medical school. I've been there a few months now, and I'm working with new medical students. Great. And we're doing kidney. Surprisingly difficult subject for what's not a very difficult organ. And so they'd had all their PhD lectures a year ago, and then they had a quick brush up in second year, and now they're talking about disease. So I'm sort of getting them 2/3 of the way through. And we're talking about glomerular disease. And I'm talking about, okay, so what 2 tests do we use to do glomerular disease? And they just can't answer me. So they've been through months of thinking about kidney, but yet they don't know how to think about kidney clinically. So then you prompt, right? You say, okay, well, we want to do two things. Two things really are good for overall kidney function. Give me GFR and give me urine albumin. Got it. They knew that. Those are punching bells. They've heard those words. Everyone's smiling at me. And I go, so why does albumin work? And they just give you this, God, I wish I knew the answer to that. That's such a fair question, and I just can't tell you. So then we say, okay, what do I need to build a medical student? And there's two ideas that everyone knows. Everyone knows these ideas, except they can't use them. The first is, show me the trilamellar filtration organ, except no one knows what trilamellar is. So right off the top, I've got a vocab. Tri for three, laminate to form a layer. Okay, that's pinging bells. They go, what you filter through. Ah, well, everyone's got that. And then we walk through and you say, okay, show me each of the three layers and what they do. Mixed response. Well, here I'm teaching what they learned a year ago. So did we teach anything last year if I have to rebuild this? The second one is, so why is GFR, which is just a glomerular function, why is that good for the whole nephron? And I'll tell you the problem, because here's my glomerulus. This is the universal picture we're all taught. I was taught it in 1972, just like everyone else. Here's the glomerulus, and here's the blood supply coming in. Here's the blood going out. And that's the end of the picture. And you go, hey, but what happens here when it goes out? That's a really good question. I don't think I know.
I've heard you talk a lot about how important it is that students learn to think like a doctor. But why is that so hard to teach? Why is it they're coming from other classes and they just don't know it?
Because they're not being taught from a patient-centered point of view. So when I get really good students, like for example, the students from India, they tend to be some of my very best students. They have all of the facts perfectly in the command. And once I show them how to use them in patient-centered care, they only need to hear it once. The second you show them what to do, they go, I got all these facts. I can order them in a heartbeat. With the American medical students, they haven't been beaten as hard, so they haven't really got the perfect mastery of facts that the best Indian students I teach. So I kind of have to go back and buff up their facts a little bit, and then they got it perfectly. If a student doesn't have the facts, then I've got to teach the facts, and then we have to stop for a day while you internalize them so I can build on them. So when we say medical reasoning is built on a foundation, how do you teach a glomerulus if a student has no idea how a cell works? So when here's a common problem that none of my students can ever do. I say, what's an epithelium? Like the most basic idea in how our body's organized. And in the 3 months I've been at my new school, you know how many students have been able to explain that to me? Zero. It's not that they're not trying, Allie. They're obviously really trying. But the second I point out anything that touches the outside world has to be covered. And that covering's an epithelium. They go, well, that's perfectly obvious. Why didn't someone just tell me? Well, because no one needed that as a fact to talk about infections occur when there's a break in the barrier. So I guess you got to know what the barrier is. Yeah, the barrier is an epithelium. And then the next question is obviously, so how many types are there? And everyone agrees that's a totally fair question. They just didn't realize you needed it. So this idea of patient-centered care is perfectly universally agreed upon. And then you say, good, let's go do it. And then you see this horrible divide between the clinicians who are perfectly great with the patient, get all the way to the organ, yep, it's heart failure. And then you say to them, great, so tell me what's happening in the myocardium. Well, it's not working. Yeah, no, we knew that. That's why it's called failure. So exactly what's happening. The really good ones will mutter words like adaptive hypertrophy. But when you say, okay, good, draw me the cardiac myocyte, they've got nothing because they've just never had to use it. They were never taught it. So they're not going to be able to teach a medical student. They're just really good at saying, yep, ejection fraction's 20%, that's failure. When you come to the PhD, they can draw sarcomeres out the wazoo. But the second I say, hey, draw them in series or parallel and tell me the pathologies that drive that difference and what the heart looks like, and so how that's going to affect your ejection fraction. Yeah, nothing.
So talk to me about how your experience when you went to med school and when you were doing your residencies, how does that compare to what's happening today, where it sounds like there's this great divide in terms of what educators can teach you?
What has changed from my day? I would argue the biggest change has been the absolute polarization that the basic medical sciences is taught by PhDs, and then they're turned over in the clinical years to the MDs. And that just wasn't the case for us. You know, we were taught some PhDs, but always mixed with MDs. So there was always this reality. And so, you know, when I would go to class, I would literally walk through the hospital to get to my class. There was never any question in my mind why I was learning this. But now that we've so deeply separated the basic medical science from the clinical, this basic medical sciences sits in this isolation of facts you're going to need. Well, if you're not using a fact, it has a half-life of 1 to 2 months. When I teach students, yes, you've got to be able to do this. I just have a credibility coming out of practice. They believe me, right? But if you've never done patient care, you just don't. So, you know, you can always tell a multiple choice question written by someone who's done medical patient care and someone who hasn't. They have a different feel to them. And so this absolute separation didn't exist back in my day. The second big change is this. As best I can judge, and obviously there's lots of different schools with lots of different truths here, but the biggest change I see in my students is they don't have apprenticeships. An apprenticeship is where you go and literally work with your skilled workers, and they keep an eye on you, and they let you do jobs that they think you're safe to do. So you're actually doing them. So, for example, I can remember when I started as a pediatric clerk, we did the scalp MDs. I remember one of the scalp, these are the tiniest little butterflies you've ever seen, little tiny bells. I remember there was this particularly different one to do that one of my classmates had done. And I walked in, he came out going, that was the hardest thing I've ever done. And I walked in to look, and there was this giant mound of tape and gauze, and because he couldn't get it to be settled, right? Because he hadn't put the tip in far enough. And so this little tip went in and then it wandered. So he had to build this elaborate pyramid of structure to hold that little tiny tip, and it lasted, of course, till the baby moved his head. So once you've tried that, you have a totally different feel for what IV hydration means, and you truly are part of the team. So you were supervised very closely and allowed to do what the team judged you safe to be. Now, the one thing we were never allowed to do was deliver babies, because medical students are completely untrustworthy, and so that was way too important. So I didn't actually deliver my first baby until I was an intern, but we were certainly in the delivery suites. So we knew the moment was coming. So it's this idea of the difference between an apprenticeship, where you're the most junior, inexperienced part of the team and you do everything that's unpleasant until you're deemed trustworthy to do more, supervised by the next person up, versus observerships, where you're just passively standing at the end of the table. So I can remember I was in the OR as a very junior clerk, you know, and it was just really boring. I mean, I was just standing at the table. I was told to put my hands right here so I couldn't contaminate anything. And they got a little trouble, and they were picking through some scar tissue. It was slow. And I just couldn't control myself. I knew it was inappropriate. The devil got my tongue. And I just went, so how's it going up there? And the surgeon turned and looked at me and said, you, out. I just got kicked out. But I was allowed to get kicked out. It wasn't, who are you? Right? It's like, okay, we're teaching you professionalism. Sometimes you just shut up and lump it. We don't care if you're bored because you don't matter. So it was pretty funny, and the residents absolutely loved it. I was pretty mortified, but it was totally fair. I kind of thought I would get kicked out in all fairness, and that was way better than what I was doing. Yeah, but you know, you're part of the team, and you're taught all alongside everyone who's part of the team. I don't see that in my students. That's a big difference too. So they didn't care what we knew, right? They knew that they were going to just pound on us once we got to the clerkship.
So tell me, is it possible to train someone to teach and think the way you do?
Why, when everyone agrees that this patient-centered learning is right, why aren't we doing it? Well, we've talked about the two gaps. Clinicians are great from chief complaint to organ in trouble. And the PhDs are great from their protein to the cell. And then there's this horrible gap between the cell to the structure to the organ. So no one is thinking completely. So here's the challenge. If I said to you, heart failure, and I said to the PhD, take your sarcomere and tell me how that sarcomere relates to this patient's heart failure. Well, the PhD can't. They can tell you all about the protein, but they really can't walk all the way through that little kid with muscular dystrophy and how they first recognized the climbing problem, and then they knew they had the diagnosis of dystrophin. Now the protein we can talk about, but then we have to talk about, why does the cell degenerate? Why is there fatty replacement of the muscle? You know how many books I have seen that have explained that? None. It just magically happens. Oh, we all know they have fatty muscles. Well, that's kind of a gap, isn't it? And then recognizing dystrophin is common to striated muscle. Okay, so when I ask anyone, and it can be anyone except a PhD in histology, what's a striated muscle? You know how many people have answered that correctly in 5 years? You got it, 0. So when I say there's 3 types of muscle, skeletal, cardiac, and smooth, you know how many people can intelligently say, well, they're designed differently. So you need dystrophin for the heart and skeletal muscle because they're striated and have Z lines. You know how many people are thrilled to hear the word Z line? Just me. No one else, wow, that's taken me back. That's what they mostly say. They don't actually use Z line in understanding how dystrophin anchors a cell and how that cell, when it contracts, it can't just be a balloon. You know when you squeeze a balloon and it all pops out around your fingers? Yeah, that's really damaging to a cell. So when a cell contracts, it has to be held smoothly and uniformly so that you don't get that disruption to what is basically a soap bubble. Your membranes are not strong. And dystrophin controls that contracture so your cell doesn't kind of wear out. So you can imagine if you're contracting like this as part of a group with Z lines and sarcomeres, those organs will fail. Okay, you don't know any histology. Isn't that a good story?
It's a good story.
Yeah, you sort of go, wow, I want to see a muscular dystrophy person because the skeletal muscles and the pseudohypertrophy of the calves, I get why those cells are degenerate. Because it turns out when we anchor the cell, it's not a tug of war. It's not for the pull of the cell. It's for when it contracts, it's so that it gets an ordered shape that over years doesn't break down too fast. But then, Ali, that goes to a whole different idea, which is, tell me about injury. You know how many people can sensibly talk about injury? You got it. No one.
There's the issue. We don't have people who have a sense of completeness in medicine.
And run it over time. They have to be built on deeper ideas, such as, when I say injury, give me some examples. You know how many people have built into their head, they all get infection. They all get trauma. We get that. But how many people recognize if you ask a heart to beat too many times a minute, it will break down, not over months, over decades? How many people build it? That's actually an injury. Okay, good. How does the heart respond to that? There's no foundation. I have to stop and build that up.
So you have a couple people on your roster right now, a couple of colleagues who have, dare I say, drunk the Dr. Tisdall Kool-Aid.
Very much so.
How did you get them to become the complete medical educators that they are now?
It all starts with one of the really most thoughtful educators I ever worked with. My first place is at American University Caribbean. I worked with Hiroko Yoshida, who was this very able, very lovely woman. And she recognized that I made her laugh. We just got along really well. And she recognized I was the real deal coming out of practice. And so because I had such a high degree of affinity and trust in her, most days when I was lecturing pathology, I would come and tell her my experience. So she literally over 3 years watched me mature as a teacher and guided me. And so what happened was I started, like every other lecture, I taught Robbins. And I promise you, after one semester, I went, that's the stupidest thing I've ever seen in my life. This, Robbins pathology should be banned from medical schools. Not just, it's not a resource. Ban it. It harms medical students. No one should learn there's more than 12 types of testicular tumors. No one. It's harmful to think you do. Where's all the lab testing in the book? Testing teaches pathophys. So you've got how much lab testing? Oh, 0. Right? It's a book designed for first-year pathology residents. I know, I was one. It's fine for that. It's really bad for medical students. So the first thing I did was I took my Robbins and used it as a stand for my computer. So that was my use of Robbins. It was a perfect 3 inches height. Then I started saying, but we're training doctors. So the first thing I started doing was when I would do congestive heart failure, just as a common example, I would say they have shortness of breath. Who would have thought that's revolutionary? It was hard for me to believe, and yet I was the only one. So Hiroko very carefully nurtured, guided, and encouraged. She'd come to class. She was very helpful to watch me evolve, offering her very deep experience. So by the time I had left my 3 years of teaching pathology, I was well on the path to teaching pathophysiology and always linked to patient symptoms. Then I went to a company that was doing step 1 prep. Well, now you have to teach all of pathology in 42 hours. How could anyone think that's sensible? So I sat down and said, well, what can I do? And remember, I've got 3 years experience with some very good people helping me. And I said to myself, well, you know what I can do? I can teach them really tight clinical stories. So over my 6 years of doing this 10 times a year, you know how much feedback I got? I'd go in and teach for a whole week. Every day they would grade me whether I amused them or not. And then 1% would call me to say if I helped on the exam. So, boy, you talk about real life volume. It was fantastic. And by the end of it, I had come to believe it's not only pathophys. Pathophys serves clinical pathology correlation. So the first morning I'd walk into 100, 150 students and say, so 68-year-old male presents to the ER with 3 hours of shortness of breath. Go. And all the students would give me this look. It was so much fun. They give me this look of, okay, I've been studying for 2 years. I'm $150,000 in debt. That's a perfectly fair question, and I don't have a clue. So that every one of them bought into that scenario. And then I would build them. I'd say, well, to do that, let's do some anatomy. And I would start with the regional, and I'd walk all the way through, no gaps, all the way through to the protein. And then I'd say, well, you got to have some phys here. No more than you need. And I'd build in the phys, right? So if you came to me and said, well, what phys do I need for congestive heart? I would tell you, you need 3 formulas. And that's all you need. So you know all those 6 weeks you spent being tortured on all those Wiggins curves? Yeah, well, okay. Yeah, no.
So your method of teaching started to develop, and it sounds like your colleagues, the ones we brought onto the podcast and that you've mentioned before, they started to adopt a lot of your philosophies.
So let's talk about that. So Hiroko goes to a new school, and she recognizes they're in trouble. Their students, the exam has changed, and their students are really doing poorly. And she knows a guy. That would be me. She knows someone she's seen the scores respond very fast to this. So she has the political clout to have me come and do every trimester, I would do a week as exam prep for the students, and the faculty were expected to come and see. And out of all those faculty, they understood perfectly what I was doing. And then all of them said, and I can't do that. But then what they didn't say was, I guess I better learn. Instead, they said, I bet I'm going to last here long enough I can just slip through the door before it shuts behind me. Except for one person, Eric Nielsen. And Eric came, saw, and said, well, that's better. And he was young. He had nothing to lose. He was the sim director, the simulation lab director. And so each week I would come, he would grab me, and we'd spend a whole afternoon, and I would walk him through an organ system. And then he would use it for his students. So he not only saw it, he then did it. And I could see every trimester I'd go back and he would just be better and better. And finally, finally the committee voted me off the island after, I think, 2.5 years. But by that time, he was as good as me. Eric Nielsen is teaching students all day, every day in the sim lab. And so he's not just thinking this is a really good idea. He's taking this and using it the next day. So he's getting all these repetitions in. And each time I come to the island, he gains new organ system. So he's literally been walked through this system and the next day practices it with a copy of the book. So anything he forgets, he can just remind himself. So by the time I'm done, he's as good as me. But remember, he's really practiced. Now, his clinical superior was Nancy Selfridge, who you've seen on this. And she's watching all this. She absolutely agrees, but she's literally bound up by her administrative duties and just hasn't got the time and the energy to do it. So she's sort of watching with a bit of discontent as Eric is getting way better than her. And she's sort of stuck being a bureaucrat. Fast forward, a new med school starts in the Bahamas, and both of them go there. And they go there because Nancy Selfridge has watched me and Eric for a few years now, and she says, I'll come to your medical school if we do it this way. The compromise they came to was, okay, we'll sort of do it this way, meaning we'll sort of have subject-based learning, but you guys get the whole last semester to switch it to patient-centered. So that must have been about 2 years ago, and they invited me to come and be there for that semester flip. And then Eric had to leave the island for personal issues, so I got to do it the whole next semester. And it was every bit as good as we hoped. I mean, if there was any question about the theory, that was put into practice. It is fantastic. And then Eric made another innovation, which was we stopped doing the patient-centered and made the students follow the curriculum. So the students started presenting it. And that was insanely good. And all these students who are not good students, these are Caribbean medical students, they're perfectly smart, lovely people. They're not good exam takers. That's why they're there. All these people using this method could just watch their scores go up. They could watch the questions become really obvious to them. It was really gratifying. And all the while, they're getting ready for clerkship because they're going to be better doctors. So then we come to the final piece when their inaugural class has to write step 1. And so we get a third kick at this can, and I make the one last innovation. Every day I would teach something, and they all had to write me a multiple choice question on it. So I could literally watch their brains evolve, and over 12 weeks, I could see their brains gain in sophistication, in insight, in ability. And so, yeah, any question anyone has about this, I can promise you, this isn't my opinion. This is proven on the ground in the field. If you've got the facts, we can resort them in a matter of months, and you will watch performance go up 15 to 20% just by knowing how doctors think.
So we can talk about scalability for a second. Obviously, we're trying to scale you by training other educators to teach students how to think like a doctor. In the meanwhile, and I know, Dr. Tisdall, you talked about this on your platform before, we are building out a community. We are in the process of getting the framework set up for an app and an online area where students can buy a membership and they can get access to you. You will be going live. You will have uh, questions on there. Talk a little bit about what you're hoping this community will become and how it'll help students. Is this a replacement for med school? What exactly is it that they will be getting?
So scalable was always the magic phrase, right? I know I can walk into a room of 150 students, and I know that by Thursday, I can improve their performance on UWorld by 15 points. Just not by giving them facts. How many facts could you give in 4 days after 2 years? That's not the point. The point is, do you understand why you need those facts? So yeah, just one student at a time, I know this works. The question is, how do we do it 1,000 students at a time? And how do we do it without me having to get up at 8 in the morning and stand there till 4 in the afternoon? So scalability has always been the discussion here. This is what I think. I think that if you have someone walk through, hey, we're starting hard. I want you to read the first chapter on clinical pathological correlations so you can do the symptoms. I want you to do the second chapter on structure function so you've taken all of your course learning, but now you see how doctors are going to use it. And then go do your standard pathology in a clinical way. If someone sort of walks you through quite quickly, this is how I want you to learn it. That's pretty easy to do, and I don't have to do that in person. So I'm pretty sure I can do that with video, with good reading, with good drawings. I'm pretty sure I can do that without you needing me live. But then you have to go away and learn it. And I'm not kidding when I say you have to go draw it. So just to come back to what we were talking about. So Eric Nielsen watches me do it. He's teaching every day. He masters it. He's wonderful. Well, Nancy Selfridge is watching us do it with some chip on her shoulder because she's a bureaucrat, right? So she gets some patient contact, but she doesn't have time to learn this. Well, fast forward, she's now at this new medical school, and I've been invited to help with the inaugural class. Well, just like I did with Dr. Yoshida, every day I would teach, and I would stop by her office and tell her about the experience. And she's teaching a lot more now. So I'm there to say, well, this is how I see it. You go adopt it to your means. So she's dipping her toe in the water, getting experience, working with Eric and me. And Eric is going back into practice. So this semester, she's going to be running the final semester patient-centered flip for her students. And we're going to get her back on the show to say, okay, you've done it for the first time solo. Tell us about the medical educator experience. And obviously Eric and I are around, so we'll, she can reach out to us. But yes, how do we scale us? The first thing we have to do is create medical educators. Here's the challenge, Allie. I don't think there's anything that's hard to do that can be done without intense small group tutoring. So Eric had that from me. And then he went and practiced. Nancy's had that from Eric and me. Now she's going to go practice. How do we do this for the students? Well, first the student has to put in the work. Go learn the symptoms, go learn your structure, go read through it once so you've got it in your head. Now you can come back to me and we will do small group intense tutoring, which is what I'm doing at this new medical school. If you have the facts, you can fix it like that just by learning them the right way. It's really hard work. You can't cram it. But that intense tutoring really works, and that's what I'm really going to put to the test in my new medical school. I can say 3 months in, I really like it. The challenge is only a handful of the students recognize that you've got to do this final tutoring step. It's not comfortable because I say things like, hey, what are the striated muscle cells? And you kind of feel like a booby because you sort of go, well, shouldn't I know that? Well, I didn't realize that was a thing. So the question of scalability is, how much do you need of me live in the intense small group tutoring? And so that's why we're going to form this community. That's where you can come and teach yourself the symptoms and the structure and the basic material. I think you can teach yourself that if I give you a quick look-see at how to do that. What you can't do is you say, I think I know it. Do I? Well, for that, you have to come to a true medical educator. So you can't go to your surgeon or internist. As we've discussed, they aren't going to do the proteins. And you can't go to your subject-based expert because they're not going to tie it into immunology and anatomy. So there's only a handful of us, and that's what this website's going to be. We're going to start with this small community of people that have really committed to this idea that we are medical educators. Hey, immunologist is out. I can pinch hit immunology, right? Oh, anatomy's gone? Good. I've always wanted to get my hands on anatomy because now I'm going to teach you clinical anatomy, right? Medical educators know what everyone else teaches so that when they approach a patient problem, they can bring in those elements of the basic sciences that you need for that problem. Not generally this is important. No, specifically, you need to know, hey, here's tuberculosis. Let's talk about psychosocial cultural. Well, you can't ignore that because it's got to be exposed to the organism. Then we've got to go deeply into microbiology. Tell me about the cell wall structure. When I say mycolic acid, what does that mean to you? I've had students, I'll give you an example. So one student came in and said, yeah, so what's the wax factor? And I went, well, thanks for the update from 1920. When they were first growing the organism, all they had was looking at it. And so they recognized on certain media, it had a characteristic growth pattern. And so they described it that way. Well, we don't do that anymore. We don't need to do it that way anymore. But, if you're reading an older book, that was important back in the day. But how is a student supposed to know? That's a really fun fact. We're talking about how mycolic acids affect growth shapes on different media, but that's not really, there isn't time for that kind of stuff. That's what you do when you're an intern and it's a snowy night and you're waiting for something to happen. You sort of drop into the rabbit holes. So when I say to them, well, if you've got wax, then I have to stop. So what's a wax? Well, no, crickets. So now we've stopped. Now we have to break off. Mycolic acids are waxes. What does that mean? And then we talk about virulence factors. Well, I was talking to my students a month ago. They didn't know what a virulence factor was. Well, I can't go on if you don't. So we had to sort of talk about what's pathogenic and opportunistic in immunodeficiency diseases. Time is always running. But if I don't, then you're memorizing. So you can see how when you come and talk, how many of our great internists who know all the current guidelines for the antibiotics for first exposure TB, how many are going to talk at that level of the basic sciences? So when we say we did an acid-fast stain, how many are going to talk about what the structure of that wall is? Because that's part of how we think of the organism, and that says if it can't be digested, what does the body do when it recognizes something foreign and can't digest it? Well, it forms a granuloma, the single most important hallmark of TB. That's the body's response. Well, okay, so let's walk through that, how that works. Well, can your internists do that? Are they really happy making the Th1 cell and the cytokines and, no, they're not. So it's not enough to say, oh, I've seen 1 million TB patients. Yeah, but we have to build that onto the basic sciences. And with all due respect, doctor, you know neither the structure of the organism nor how the body creates a granuloma. And as we've seen with all of us, we all came out of practice and none of us know that. We've worked really hard. You notice Dr. Selfridge, she's 8 years from when she first met me. She's finally now got a place in her life where she's going to do this. So if you think you're coming out of practice and you're a medical educator, no, you're not.
Dr. Tisdall, we're going to definitely be doing more of these unfiltered conversations as we move forward. For anyone who hasn't yet, be sure to subscribe. Again, we are in the process of building out the community. We are in the development phase. We're going to be posting updates here on this channel about when it's ready, where to go, how to sign up so that you can get access to Dr. Tisdall and truly learn how to think like a doctor, which you may not get in medical school.
So the students should understand we're starting this community. This is a reciprocal teaching moment. So I'm really happy to show you how clinical medicine is built on basic sciences. But you got to understand, when you come and ask questions, you teach me what I have not taught well. One of the reasons I'm confident as a teacher is I've failed so many times. I've taught a subject and the student comes back and asks a question that says, then I didn't teach it well because you shouldn't be asking that question. So I'm really looking for the students coming and teaching me how to be a better teacher.
If you guys liked this conversation, be sure to check out Dr. Tisdall's discussion with Dr. Selfridge right here. It's a great conversation where they go through some of the topics that we discussed today. Dr. Tisdall, we will see you next time.